Professor Henry Potts. So Henry Potts is a professor of informatics at the UCL Institute of Health Informatics. After a first degree at Cambridge, Henry did a PhD in health psychology at King's College London and a master's in applied statistics at Oxford. He's worked at UCL since 1999. His current focus is on how we best evaluate digital health products and services, including AI. He was the lead author of the Gov UK resource Evaluating Digital Health Products. However, he also has an interest in pandemics and worked on the COVID-19 response, advertising the Department of Health and Social Care and Cabinet Office, and participating in the SAGE subcommittee SPIB on behaviour. So please join me in welcoming Professor Potts.
Thank you. Hello, everyone. I'm Henry. You can email me. You can find me places. There we go. So David was saying he'd rather good data than good models. So I'm going to talk a lot about data and how we measure behavior. I'm going to talk about 3 pandemics that we have measured behavior during. Swine flu, COVID-19 and Mpox. Obviously, I'm sure you can identify which virus is which. I think it's COVID, Mpox, swine flu. So let's jump back 18 years or so to swine flu. Do you remember swine flu? You know, not the most popular pandemic. It's not up there with the big ones. We think swine flu probably appeared summer 2008, possibly in Asia. Flu viruses love to recombine with other flu viruses, but it was only spotted. First confirmed case was in Mexico in March 2009. First confirmed death was then in April 2009, on the same day as the first confirmed case in the UK. And on the 1st of May, a study began. The Department of Health started collecting some data, which I'm going to tell you about. The pandemic got declared on the 11th of June, the first UK death, 14th of June. And by July 2009, the Department of Health had a worst case scenario, having done some modelling, of 65,000 UK deaths, which didn't happen. Mass vaccination later in the year, pandemic was declared over the next year. So, as opposed to a worst case scenario of 65,000 UK deaths, we think, it's hard to know for certain, but we think worldwide deaths from swine flu would be about 18,000. Mildest flu pandemic on record, maybe a third of the mortality rate of a typical flu pandemic. We can compare it to, anyone here remember 1968, 69? That was the last previous big flu pandemic, which had maybe 1 million deaths. UK figures maybe 300 deaths. Not to say it wasn't still, you know, this was 18,000 deaths that wouldn't have happened otherwise. There was a lot of morbidity. I remember having swine flu. It's still the illest I've ever felt. But this is a behaviour plenary. So why am I telling you about pandemics? Well, behaviour is key to preventing and managing pandemics. Pandemics generally involve novel diseases, or at least novel strains. So we don't have vaccines for them at the start. We may not have any treatments. But the only thing you can do at the beginning of a pandemic is modify people's behaviour. And we want people to do behaviours that are going to prevent transmission, not encourage transmission. Don't lick pigs. Not that I think actually that's how you call swine flu, but it's probably still unwise, yeah. So what happened when swine flu came out? Well, the government as an information campaign, and they had this poster. Do you remember this poster? Anyone? I still very occasionally come across these posters, over a decade later, that someone's left up on the back of a toilet or somewhere. But this was key to the campaign. Let's have a poster. We want to tell people two things. Catch your sneeze. So when you sneeze, get in some tissues. Don't spray it out. And wash your hands. Very effective at minimizing the transmission of flu, those two things. So the Department of Health produced this and an associated campaign, and it was everywhere. And what they wanted to know was this campaign successful? And so they collected some data. They did weekly telephone surveys, so ringing up a random selection of people until you got about 1,000 each week, and asking them a bunch of questions. So the Department of Health came up with this bunch of questions, and it was sort of where we actually did all the data collection. And then me and Susan Mickey had what we bid for this opportunity to analyze this data set and look at what it showed, look at predictors of behavior. And then we brought on board a guy called James Rubin. So I want to go back to this data as a sort of a nice starting point to look at the sort of things we could do. And I'm going to tell you a little very basic modeling, but then mainly I want to come back to these challenges in how we collect this data. So what did this data show? So if we look at the early behavior, so this was from the first 5 UK surveys, data on about 5,000 people. People were asked, do you carry tissues with you? Have you got any antibacterial gel? So about a third of people were carrying tissues with them. Not ideal. We want more than about 10% have bought some sort of antibacterial gel. Okay, are there any predictors of that behavior? Well, the one thing we know is often a very good predictor of health behaviors is worry. If you're worried about something, if you're anxious about it, that's going to drive behavior. And so we asked people how worried they were, and yes, I mean, these are just simple logistic regressions. We've adjusted for some demographics. And yes, if people were worried, they were more likely to carry tissues, more likely to buy sanitizing hand gel. Another thing we know works is we might call mere exposure. If you just show an advert a lot, it gets into people's brains. And so this was everywhere. People saw this or similar images. And so the thinking was, okay, we asked people, have you seen this post or have you seen the TV advert or whatever? And people who said, yes, I've seen one of these adverts. Was that associated with behavior? And this was, in a sense, the Department of Health's main question for them, because they were paying for this health promotion campaign. They wanted to know whether it worked. And yeah, people who saw the adverts were more likely to carry tissues, more likely to buy hand gel. These odds ratios are lower than these odds ratios. It's not as big a driver, but that works. This is my only model. This is what we tried to do with the Department of Health data. We were like, okay, well, let's try and apply some health psychology thinking here and say, well, what do we think's going on inside people's heads that might be driving their behavior? So this is, you can find all these papers online, but let's just start with carrying tissues. What's going on inside someone's head that might be driving that behavior? Well, we had various questions. We had a question on, are you worried about catching a swine flu? We had a question about hygiene efficacy. So basically, do you think that doing these things works at preventing the spread of flu? So if you don't think hand washing is any use, then presumably you're not going to be encouraged to wash your hands. We had a measure of actual knowledge. We sort of basically had a short test where we asked people in the survey stuff they knew. We also asked them, do you know about swine flu? So this is self-reported knowledge as opposed to us testing people's knowledge. And we also asked people, are you satisfied with the amount of information you've had? And we asked them, well, have you seen adverts? We also asked, have you seen anything in the media, in the newspaper, in the news, etc.? This is just regression models. This isn't very complicated maths. Could have done structural equation modeling, but seemed like a faff, so we didn't. That's my general attitude to structural equation modeling. This is what we found. So I'm going to go through this to sort of explain our thinking from a health psychology point of view. So what did we find? Well, controlling for these various factors, exposure to adverts drives carrying tissues. If people had seen adverts or said they'd seen adverts, they were more likely to carry tissues. But there were also these effects going through various mediating variables. So people who'd seen adverts knew more about swine flu. Their knowledge was better. They tested better, okay? However, if people's knowledge was better, they tended to be less worried. People are worried when knowing stuff can decrease your worry about something. If you're worried, you're more likely to carry tissues. And so there's a potentially, while exposure to ads is increasing the chance for carrying tissues, at the same time, it's also making you more knowledgeable, and being more knowledgeable means you're less worried, and being less worried means you're less likely to carry tissues. So the plus means if you're more worried, you're more likely to, but this is driving it down, so it's going down. However, there's more pathways here we noticed. So for example, if you think hygiene methods are effective, you're more likely to carry tissues. And what we found is exposure to adverts predicted people thinking they knew a lot about swine flu. So thinking you know about swine flu and actually knowing about swine flu were related, but they're distinct concepts. So people who saw the ads thought they knew more about swine flu. Thinking you know about swine flu meant you thought hygiene methods were more effective, and that drove carrying tissues. I'll jump to this one. If you saw stuff in the media that also made you think, oh, I know about swine flu because I've read some newspaper articles. And again, so that drove efficacy. And that meant you're more likely to carry tissues. But also, if you saw more media coverage, you tended to be more satisfied. You reported being more satisfied with the amount of information you'd had. So seeing the adverts, the posters didn't affect that. Seeing news coverage that affected that. And if you said, oh, I'm satisfied with the amount of information available, well, then you were less worried, and worry drives the behavior. So there's different effects going on here. We were quite concerned about media coverage. Remember, media coverage might be misleading or unhelpful, but certainly earlier on, what we saw in swine flu, and I think this was also during COVID, was that to a large degree, media repeated what government said. Government said, do this, and media would say, government says, do this. You know, a lot of the reporting was very straightforward. So generally, we saw media coverage as being a great way of just amplifying these public health messages. At later points, certainly in swine flu later on, when swine flu had been a bit of a damp squib and there hadn't been 65,000 deaths, you then got this backlash and the media were like, oh, why did we do anything? And then maybe we saw different things going on. So that's just an example of a very simple sort of modeling that we can do to sort of try and understand what factors might be driving behavior. We know that worry predicts behavior change and we think drives behavior change. Some people, though, are concerned that we shouldn't be worrying people. I mean, is it ethical to scare you? If I scare you, I can get you to change your health behaviors and probably all your other behaviors. But should I be scaring you? So one of the things we felt quite positive about was, oh, actually, there are other ways of shifting behavior that don't necessarily involve scaring people. We don't have to scare people. Scaring people is very effective. We don't necessarily have to scare people because perceived efficacy is also an important route. People need to believe that the behavior will work. And this mere exposure, if you just bombard people with these messages, it goes in. So we did that study. That was great. For that study, we had this data from the Department of Health. They had designed that survey, and they were very concerned basically with, are people seeing these adverts that we're paying for? And we looked at that survey and we did some fun analyses, and that was great. But we were like, we wouldn't have asked these questions if someone had asked us, And so we got another grant, and we were like, great, what we're going to do is we're going to design a better survey. This is the survey you should ask in a pandemic. That was our plan. And we thought, well, let's test our questions. There's no pandemic on when we're doing this, but we could go to the public and ask them, try different wordings of questions to see whether people understood our questions, to see whether they worked. And we developed a survey questionnaire, the flu test, the flu telephone survey template. So you can read this paper. It's not very exciting because it's us dotting I's, crossing T's, just very rigorously working out how best to ask all of these questions and what questions you need to ask. And then the idea was, great, here you go, put it on the shelf. When the next pandemic happens, you can reach for it, change whatever the name of the new pandemic is, maybe throw in a few more questions, and we'll be in a better situation. We'll get better data out of that. So we did that. And then we waited. What we did, we went back to doing whatever we were doing before. But 6 years later, we were here. We were in Downing Street. We met Dominic Cummings. I was at the first meeting they met Dominic Cummings. I was at the second meeting. I didn't meet Dominic Cummings. I didn't meet Larry either. In fact, we went in the daytime. It's just, this is a better photo. But anyway, this was like Feb, March. The survey was being used. So this is an example of the slide deck that was going around government based on our survey, which had been adapted. So this is the sort of infographics that they were doing before, we'd really sort of come back into the fold and said, oh, these aren't very good infographics. But anyway, I don't think this is a particularly sensible way of showing the information, but this is what they were doing at the time. So this is a question about, again, how worried are you by coronavirus? It wasn't even called COVID at this point, you'll remember. And you'll see the very first survey began on the 28th of January. So it worked, the system worked. By designing something beforehand, they were able to get it out there at a very early phase when a lot of people still weren't thinking about coronavirus. I mean, it was in the news, but not many people necessarily taking it very seriously. And then we were collecting data every week at this point. That changed later on. And you can see here, this is a somewhat confusing infographic, but there's different options for how you answer the question on a Likert scale. And if you look at the green line, this is proportion of people saying they're extremely or very worried. And you can see it's creeping up from late January to early March because it was all getting more real. And we also introduced questions like this, what is the perceived risk to the UK population? What is the perceived risk to you personally? You might think, oh, this is terrible, but I'll be fine. So that might have implications for your behavior. Or you might think, oh, I'm at threat. maybe the rest of the country isn't. Perceived severity of illness, perceived likelihood of catching COVID. So you are going to act if you think COVID's severe. If you don't think it, think, oh, it's just a cold, whatever, you're not going to act. So you're going to act if you think it's severe. You're going to act if you think you're going to catch it. If you think, oh, well, I'm not going to catch it, well, then why would your behavior change? So these are important things to measure. Likewise, if you think you're at risk, you're more likely to behave in whatever way we're pushing. Let's get methodsy, because I love methods. Bunch of surveys. Oops, oh dear. Awesome. Bunch of surveys. So weekly surveys. What are these surveys? They're for adults living in the UK, about 2,000 each wave. Surveys were being done weekly, later it moved to fortnightly, then it went back to weekly, then it went back to fortnightly. Generally, the data is collected over a 3-day period, Monday, Tuesday, Wednesday, but if there's a bank holiday, Tuesday, Wednesday, Thursday. I didn't realize quite how many practical problems there are with doing these things until this all hit for real. What we're doing here is using online market research panels. So people have signed up to something like YouGov to do surveys. And then we go there and we say, great, send out some surveys. People get paid a small amount to do each survey, and then we use quota sampling, so here age and gender interlocked and region, to ensure that we get a vaguely representative sample. Now, do you remember what the name of the project was? Flu test, the flu telephone survey template. The swine flu work was done on ringing people on phones. 6 years later, ringing people on phones doesn't work. Partly, online surveys are a lot cheaper than trying to do random telephone surveys. Partly, you can't do random telephone surveys anymore. People don't have landlines. People don't pick up the phone if you ring them from an unknown number. It's simply become not practical to do it that way, or very, very difficult. So we're using this online market research panels. Are they representative? Are the sorts of people who sign up to do surveys like this? And then when the survey pops up in the email, do you want to do, and it says, well, this survey is on COVID. So people can decide whether to do the survey or not. Are they representative of all people? Who knows? But that's what we did. We generated lots of data. There's a whole bunch of papers online. You can find them. I mean, you get stuff like this. This is just one example where we were asking people whether you can identify the most common symptoms of coronavirus. So what we wanted was if people had symptoms, they would get tested and they would self-isolate. But that requires people to know what the symptoms are. If you don't know what the symptoms are, none of this is going to work. And so what we found, for example, is that knowledge of symptoms, well, it peaked around maybe nearly 3/4 in that sort of early crisis phase. And then it sort of was more like 2/3 or less. So the purple line is if you knew that a cough and a fever were symptoms, and then anosmia was introduced as a symptom later on as well. So people don't know what the symptoms are. This is a big problem for a lot of your attempts to drive behavior change. And so we just banged the drum on this a lot. We just kept saying, we need to keep getting that message out. And didn't really work. I want to get in the weeds though a bit about method. One of the questions we asked was about long-term conditions. Do you have a long-term condition? Let's say you've got asthma or diabetes. You might be more concerned about a pandemic. You might do more of the behaviors that we want people to do. So that's an obvious question to ask. And so the data's coming in every week, every fortnight, and we're looking at the data, and we notice there's this sudden drop in the number of people in long-term conditions. We thought, well, this is weird. What's happened? Where's everyone gone? And then what we worked out was that someone had changed the survey. So we were analyzing the data. The Department of Health was also doing analysis of the data. The Department of Health was sort of altering the questionnaire, and we'd input on that, and other people would input on that, and it was all very complicated. But we didn't control the whole thing, and we couldn't. It was far too big a project. But sometimes changes would happen that we didn't know about, and we'd see these things in the data. And so what happened here was the old version of the survey, you'd get to a question, and there'd be a long list of things: asthma, diabetes, some long-term condition beginning E, epilepsy. So alphabetical list, lots of long-term conditions. Do you have? And then you could tick each one you did. And then someone had changed the survey to make it easier. So then instead, one question came up, which was, do you have a long-term condition? And if you ticked yes, then you got a long list. Which long-term condition do you have? Massive change in how many people reported having a long-term condition. That's the problem with surveys. You make these minor changes to wording that you don't think matter, and suddenly your numbers shift hugely. So here, presumably, lots of people, long-term condition is a bit of a healthcare jargony thing. You might not think of it. What's a long-term condition? Do I have one of those? Oh, but I know I've got asthma, or I don't have asthma. So we then said, let's switch back, because, by that time we had 9 months of data with the questions one way, and we encouraged consistency in the questions as much as possible. Even if we don't know we're asking the question in the best possible way, we were like, let's just be consistent at least. This graph, no one outside the research team has seen before. You were the first. We have to we submitted this paper, and the journal said no, so we had to submit it to some other journal. This is a recent piece of work we did where we were like, okay, now we're through the chaos. Let's go back and try and work out, did this work? Was our data remotely accurate? And so what we've done here is we've looked at our data, and then we've looked at data from these 2 other projects. So there's something called REACT, something called, from the ONS, the Office of National Statistics, CIS. They were using much more expensive and thorough methods to get better random samples of the population. And they were asking some of the same questions. So we're like, okay, theoretically, all of our answers should have been similar. But we were using different methods. So what happened? Well, this happened. So this was percentage of people reporting any of those key COVID symptoms. These blue ones with confidence intervals, that's our survey, the Corsair project, we called it. So that's online surveys from people who've signed up to do surveys. And you can see the number of people reporting symptoms bounces around 6%. I'll come on to this late period. This orange dots, you can see the orange dots there, they were doing this less often because they're doing it more thoroughly, and that's REACT. And then you had the ONS survey, which is green. You will see that these do not match. These are different. This is not good. There are challenges here. We were getting a much higher rate of people reporting their symptoms using a different survey method, using slightly different questions. We're not really certain why that is. ONS and REACT should be more similar methodologically, but even there, these aren't entirely matching. There's some differences. This continuous line is actually the number of people who had COVID. You'll see some weird shit going on here. So you remember Omicron hit in December of 2021, which was this much more transmissible variant that was first spotted in South Africa, shot around, and you can see COVID cases zooming up. We saw a big increase in cases in November. And when we first looked at this graph, we're like, oh yeah, that's Omicron. And then we're like, oh, hold on, that's not Omicron. There's no Omicron then. Omicron came later. We're like, well, okay, what on earth was that? We're not entirely certain. We think that was basically other viruses that cause cold-like symptoms. And we know there were waves of those that did hit around then. So we think that's what we're picking up. And you see all of our numbers go up, the orange, the green dots, and the blue dots, they all go up. But actually they're going up at different, why did green go up earlier? Why did orange not go up as much? And then, if anything, go up later? We're not certain, to be honest. We think this is useful data to collect. Using online surveys is a very practical way of doing it. Is it giving us exactly the right answer? Don't know. I think we can still, compare as things go along. We hope changes over time are still meaningful, but there are challenges. This is another graph we did. So this is asking people, have you had COVID confirmed by a test? So we asked that, React asked that. So you can see our blue line, our blue dots. You can see the orange dots. Not perfect match, but we were kind of matching on this one. This continuous line, though, that's the actual number of people we think had tested positive for COVID. And we're nowhere near. Hello?
So it's estimated cumulative percentage.
Yes. It is an estimate because it's hard to know what the real number is. Yeah. Yeah. And I don't know what modeling ONFs we're using. But yeah, we're massively underreporting. So what's going on there? So we think that's memory. We think people forget, even something that seems quite important. We also think there's probably quite a lot of asymptomatic cases. So people had no symptoms or very minor symptoms, and maybe they tested positive and they presumed the test was wrong or something. And so they don't think of themselves as having had COVID. So various challenges. I mean, maybe I should not just tell you challenges and tell you solutions, but I'm not certain what the solutions are here. It is difficult to measure behavior. My message is you need to think about how you're doing it and where possible, test those methods out. I want to finish by talking about mpox. Because there are some other angles here that point to the same issues. So mpox is endemic to parts of Africa. It used to be called monkeypox, but it doesn't, you can catch it from monkeys. Monkeys can get it, like we can get it, but that doesn't seem to be the sort of reservoir of where mpox normally circulates. We think that's rodents of some sort, maybe rats, maybe squirrels, something like that. It's very similar to smallpox, but has very different effects. Smallpox as a disease is very different from mpox, but the viruses are closely related. The vaccine, I don't know if this is still true, but the vaccine we were using back then for mpox is not a vaccine for mpox. It's just a vaccine for smallpox that works pretty well against mpox. I mean, mpox has been around for, we presume, a very long time, but the first human case was diagnosed in 1970. Didn't get a lot of attention until what happened in 22 was we started seeing widespread community human-to-human transmission outside of Africa. So not people in Africa catching it from animals, but people away from where mpox is endemic transmitting it human to human on a wide scale. In July 2022 was declared a PHEIC, a public health emergency of international concern by WHO, although they declared it over by May 2023. And then the next year, it happened again with a different variant of the virus. That there's clade 1 and there's clade 2. But I'm just going to focus on this first wave of mpox, the 2022-2023 outbreak. Now, mpox is not what we would normally call a venereal disease. It's not a sexually transmitted disease. But it is a disease that is transmitted during sex. Mpox is transmitted by close contact or contact with clothing and bedding. And sex generally involves that close contact. What we saw in the 2022-3 outbreak was that the outbreak was largely in MSM, that's men who have sex with men, who had recent sexual contact with new or multiple partners. And what happened with this outbreak, we were all very excited, as pandemic researchers, no one wanted to publish our COVID papers anymore. We were like, ooh, new pandemic, great. Maybe that's not a healthy attitude. But anyway, we were all set to publish lots of mpox papers, and it didn't happen because the community of men who have sex with men with recent sexual contact with new or multiple partners responded magnificently and stopped having contact, and the outbreak stopped. This is, of course, a community who have a long history, particularly with HIV/AIDS, who are good at mobilizing in a crisis, and they did. Before really we got going, there was a lot of good community reaction. I thought there was a couple of points here, though, that it might be important to make to people from a mathematical modeling background. Firstly, I keep talking about MSM, which may, to some of you, be unfamiliar terminology. Not gay, not bisexual. In a public health context, we use that terminology because we want to talk about behavior. Identity doesn't matter. What matters is behavior. I have a friend who's bisexual. He has a wife. He's been married to his wife for many years. They have a monogamous relationship. He still identifies as bisexual, but he's not having sex with anyone other than his wife. He's not having sex with men, but his identity is still bisexual. Likewise, there are quite a lot of people who identify as heterosexual men who have sex with men on some occasions. You might wish to quibble how they label themselves. You may not. The point is, from a public health perspective, we're not interested in how people identify. What we're interested in is what people do. And it works a lot more effectively if you focus on the behavior rather than on how people might or might not identify. So thus we have this, what seems like weird jargon of MSM, rather than anything else. We published one paper on it where we did all the same stuff we'd done in COVID and swine flu, where we talked about, well, are you worried about mpox? What behaviors are you doing? Blah, blah, blah. But we then published this second paper where we looked at the relationship between age and sex partner counts during the mpox outbreak, because we thought if you're going to do any modeling of this, you need good data on this, and you need that data stratified where possible. So we did various wacky forms of sampling. So we did a population representative sample where, again, we went to these online panels. But we also did things like put adverts on Grindr. So people went on Grindr, they get an advert saying, do you want to fill in our survey? So we're targeting the sexually active population. And to finish, one of the things we observed was this. We did the survey, We asked people how many sexual partners they had in the last 2 months and in the last 3 weeks or 1 week? Can't remember. We asked people their age, we asked a bunch of demographic things. And one of the things we noticed is if you look at a lot of transmission modeling, age is treated as a key determinant of sex act frequency. And a lot of models basically say once you hit 65, you're not having sex. Or at least if you're having sex, it's just with your lifelong partner. You're not having sex with anyone else. So we don't need to worry about you. Some models even started that at 45. As someone who is above 45, this felt quite insulting, maybe. We found people in our survey had a range of different experiences, including we had someone who was 79 and reported 20 sexual partners in the last 3 months, which you may or may not consider impressive, but it's certainly something you need to think about if you're going to model transmission of a disease that's largely being spread via sex. Do not make presumptions in your modeling about how people behave. Look at the data. So that's my one take home. My other take home is that data is also probably very problematic because it depends how you sample it, it depends how you ask it, etc., etc., etc. So that's the end of my talk. Thank you.